Hello, welcome back, everyone. This is week 4, the third part of week 4 of the course on health IT databases. We're shifting gears today from SQL syntax that we did last week to something equally important, health information standards. Over the past 2 parts, we've been learning the mechanics of SQL. You now know how to create tables, define data types, apply constraints, and write queries to retrieve data. Those are essential. Those are very essential skills, basic skills. But here's the thing, healthcare databases don't exist in isolation. They need to communicate with other systems. A hospital might have separate systems for the lab, radiology, pharmacy, and billing. A patient might see providers at multiple organizations, and the data has to flow between all of these. So the question becomes, when System A sends patient data to System B, how does System B know what it's looking at? How do we ensure that the patient ID means the same thing in both systems? How do we make sure a diagnosis code from one hospital can be understood precisely by another? And that's the problem health information standards solve. And today we're going to cover the 3 most important families of standards. The standards that you'll encounter in health informatics. HL7, which has been around since the 1980s and includes the newer FHIR standard, and also openEHR, which takes a very different philosophy for clinical modeling, and the US regulatory framework called the USCDI that's driving adoption of these standards. So by the end of this session, you'll understand not just what these standards are, but why they exist, how they differ, and how they connect to the database work we've been doing. So let's get started. Let me walk you through what you'll be able to do after this session. These aren't just topics we'll cover, these are skills that you should walk away with. First, you'll be able to explain why interoperability matters in healthcare and articulate the real-world problems that arise when systems can't communicate effectively. This is not abstract. We'll talk about patient safety, cost, and workflow impacts. And second, you'll be able to trace how HL7 evolved from a 1980s proof of concept to today's mandated standard. Understanding this history helps you understand why we have multiple versions coexisting and what problems each version was trying to solve. Third, you'll be able to describe the basic structure of HL7 version 2, the version 2 messages especially. These are pipe-delimited, a format that still handles 95% of healthcare messaging today. Even though FHIR is the future, you'll encounter V2 constantly in the field. Fourth, you'll be able to explain how FHIR works with its resource-based architecture, the RESTful APIs and JSON format. This is a standard that's reshaping healthcare, and it's the basis for interoperability, and it's now mandated by the government. Fifth, you'll be able to compare when you'd use HL7 version 2 or FHIR and understand that most organizations actually use both for different purposes. Sixth, you'll understand openEHR's unique 2-level modeling approach with archetypes and templates, a fundamentally different philosophy from HL7 that focuses on clinical modeling and long-term data persistence. Seventh, you'll be able to identify the key U.S. regulations driving standards adoption, including the 21st Century Cures Act and the USCDI requirements. And finally, you'll connect all this back to how we designed the xHealth database, seeing why it has the columns it has and how those design choices support interoperability. So we have a lot of ground to cover. Let's dive on in. Why interoperability matters. Well, before we get into the specific standards, let's make sure we understand the problem that we're solving. Interoperability is a word you'll hear constantly in health informatics. But what does it actually mean? The formal definition is the ability of different information systems to exchange data and meaningfully use that data. Notice there are two parts to this, two parts. Exchange is the easy part, moving bits from one system to another. But the hard part is meaningfully use. The receiving system has to actually understand what those bits represent. Think about what happens when interoperability fails. Here are the real-world consequences. Duplicate tests. A patient goes to a specialist. Because the specialist can't access results from the primary care provider, they order the same blood work again. The patient gets stuck with another needle, another bill, another delay. Multiply this across millions of patients, and you're talking about billions of dollars wasted. Missing critical information. Imagine an emergency room doctor who can't see that a patient is allergic to a medication because that information is locked in another system. And this isn't hypothetical. Medication errors are a leading cause of preventable harm in healthcare, and many of them stem simply from incomplete information access. Manual data reentry. Without interoperability, staff end up typing the same information into multiple systems. This wastes time, introduces errors, and frustrates everyone involved. Every time a human rekeys data, there's a chance for a typo, a transposition, a misunderstanding. Fragmented patient records. No single provider has a complete picture of a patient's health history. The cardiologist doesn't know what the neurologist prescribed. The new provider doesn't know about the surgery 5 years ago. So the vision that we're working towards is simple to state. We want the right data in the right place at the right time. A provider should have access to the information they need when they need it in a format that they can use. And standards that we're talking about tonight are how we get there. I wonder if any of you out there have experienced fragmented healthcare problems where tests had to be repeated because inaccessibility or lack of interoperability. It can really hurt. All right, let's look at the standards landscape. What are the big standards? And here are the 5 biggies. There's several major standards, each with its own history and purpose. Well, let's talk first about HL7 version 2. This is the workhorse of healthcare messaging. It's been around since 1987 and handles communication between clinical systems using a pipe-delimited text format. When a lab result comes back, when a patient is admitted, when an order is placed, odds are good that an HL7 v2 message is carrying that information. HL7 version 3 and the CDA came later and tried to bring more rigor through XML and formal data modeling. CDA, the clinical document architecture, is still used for documents like discharge summaries and continuity of care records. Now, HL7 FHIR is the modern approach. It uses RESTful APIs. It supports JSON and XML, and it was designed for the web and the mobile era. FHIR is now mandated for new systems in the United States. Now, openEHR, the fourth on your slide, it takes a completely different approach. Rather than focusing on message exchange, it focuses on how you model and store clinical data over the long term. We'll spend a lot of time on openEHR because it offers insights that complement what the other systems are able to do. And finally, DICOM. DICOM has been around a long time, and it handles specifically images like CAT scans, MRIs, X-rays. It's its own world with its own complexities. For tonight, we're focusing on HL7 version 2, FHIR, and openEHR. These are the ones that you'll encounter most and connect to the databases that we've been working with. Connection to the previous weeks that we've studied. Let's show you how today's content fits into the arc of this course, because everything we learned builds on what we did before. Remember back in week 1, we talked about healthcare data fundamentals. We covered data types, what's the right way to store a date, a numeric value, or a code. We introduced coding systems like ICD-10 for diagnoses, CPT for the procedures, LOINC for labs, and SNOMED CT for clinical terminology. At the time, you might have wondered, why are so many coding systems and why it matters which one you use? Well, today you'll see. These coding systems are fundamental to the concepts of interoperability. Then back on week 2, we covered database design, the relational model, and how to normalize a database, how to structure tables so they're efficient and maintainable. Those design principles apply directly when you're building systems that need to exchange data. Then in week 3, we did ER modeling, the entity relationships, understanding how entities like patients, providers, and encounters relate to each other. Those relationships map to how standards like FHIR represent references between the resources. So here we are in week 4, and we've seen how the standards shape the data that goes into databases and how it comes out. The coding systems from week 1 show up in the standards we're discussing today. The normalization principles from week 2 apply when you're designing FHIR-compatible schemas. And week 5, when we cover joins and EHR vendors, you'll see how USCDI requirements connect to what vendors like Epic and Cerner have implemented. Everything connects. That's why this course is structured the way that it is. Now let's go back to the beginning and understand where HL7 came from. Understanding the history helps you understand why we have the standards landscape that we have. Before the standards, what were things like? Well, let's look back in the 1970s and 80s. Computing is just starting to make its entry into the healthcare space. But there's no coordination. You've got a laboratory system over here running on one computer, probably from one vendor. You might have a pharmacy system on a different computer from a different vendor, different software. And radiology has its own systems that focus on handling imaging data. You have a patient registration and billing system. They all have their own systems. And unfortunately, most of the systems don't talk well to each other. So what did integration look like in this environment? Well, whenever two systems were to be connected, someone actually had to figure out how to connect them physically. There were custom point-to-point interfaces. Every time you wanted to connect system A to system B, you had to build a custom interface specifically for that pair of systems. Your lab system speaks to its own language. Your pharmacy system speaks a different language. So you need a translator. And that translator has to be built from scratch. So these interfaces weren't cheap. I mean, they could be $100,000 to $500,000 per interface. And if you had N systems that all needed to talk to each other, you potentially had N squared interfaces. The costs could easily become enormous. The workflow impact was brutal. Nurses often had what they called terminal per system, literally multiple computer terminals at their workstations, one for each subsystem they needed to access. The lab system was on one screen, pharmacy on another, registration on a third. Imagine trying to do your job while juggling multiple interconnected interfaces. And the result was data silos everywhere, constant manual re-entry of information, and errors from all that rekeying. A nurse could look up information on one terminal and then have to type it into another. Every time you rekey data, you introduce the possibility of errors. This was the problem that HL7 was created to solve. If systems could agree on a common language, a standard protocol for exchanging healthcare data, you could eliminate those custom interfaces. Instead of n-squared interfaces, you just need n interfaces, each connecting by standards. The story of HL7 begins at the University of California, San Francisco Medical Center with a physician informaticist named Don Simberg. Between 1976 and 1979, Simberg and his team started developing a protocol to connect their clinical systems. They weren't setting out to create an international standard. They were just trying to solve their own difficult integration problems. And by 1981, they had something working. 4 very different computer systems were connected: the laboratory, pharmacy, radiology, and patient registration. They were all communicating through a standardized protocol. It was a proof of concept that showed the approach could succeed. The key insight was simple but powerful. If you create a standard protocol, you can reuse the same connection logic. Instead of building a completely custom interface for every pair of systems, you build one interface from each system to the standard. The savings multiply as you add more and more systems. Word spread through the healthcare informatics community. Other institutions were facing the same problems and were interested in hearing about this approach. So in 1987, the Health Level 7 organization was formally founded to develop and maintain the standard. Now, why the term Level 7? When you say HL7, a lot of people think there was a 6 before that and a 5 and 3. No, that's not how it was. It has to do with 7 levels. The OSI model's application layers, which we'll look at in the next slide. The name signals that HL7 operates on the application level. It's about the meaning of the data, not the mechanics of its intertransmission. For those who haven't encountered the OSI model, let me give you a quick overview. The Open Systems, or OS, interconnection model is a conceptual framework for understanding how network communication works. It divides communication into 7 layers, each handling a different aspect. The first layer is the physical layer, as you see on the slide. The actual cables and electrical signals and plugs, radio waves. It's about moving raw bits from one place to another. The second layer, the data link, it has the Ethernet or MAC addresses. It handles communication directly between connected devices. Level 3 is the network layer. And this has the IP addresses, the routing. It figures out how to get data from one network to another. Layer 4 is the transport layer, or the TCP UDP. It manages end-to-end communication, ensuring data arrives reliably and in order. Layers 5, 6, and 7 handle session management, data presentation, and application level concerns. So HL7 operates at the application level, HL7. This means that HL7 isn't concerned with how bits travel over the wires. That's handled by the lower layers. You might use TCP/IP, you might use a virtual private network, VPN, or whatever. HL7 focuses on the semantics of application level data exchange. So what does it mean when I send you a patient admission message? What fields should be included? What codes should be used? How should the receiving system interpret this information? Well, that's what, at the application level, that's what HL7 does. This layered approach means HL7 can work over any network infrastructure. The standard focuses on meaning, not the mechanics. Let me introduce you to some of the pioneers who created HL7. These are names worth knowing if you're going into health informatics. As we introduced before, Don Simberg from the University of California, San Francisco is often called the father of HL7. He developed the original protocol and was a co-founder of the HL7 organization. His practical experience trying to connect clinical systems drove the development of these standards. Clem McDonald was another pioneer at the Reagan Street Institute in Indianapolis. He is responsible especially for the laboratory parts of it, and LOINC. He brought the ASTM standard for laboratory data, which eventually merged with HL7, and this merger strengthened HL7 in the laboratory environment. McDonald later went on to lead the Lister Hill National Center for Biomedical Communications and at the Library of Medicine. Ed Hammond was one of my colleagues when I was training at Duke. We worked together for years. He was an early chair of HL7 and helped establish it as a serious standards organization and helped be sure that we communicated and collaboratively worked to solve important organizational problems. And Wes Reichel, he wrote the HL7 first version specification. And finally, Sam Schultz organized the founding meeting that occurred in 1987 and served as the first chair of the organization. So these were some of the pioneers who recognized that healthcare needed standardization, and they built the foundation we're building further upon today. So let's go back over the timeline. Version 1 was in 1987. Version 2, 1988. That's when we were able to handle ADT messages. That's admit, discharge, and transfer, plus some basic orders. And it showed the approach could work, but wasn't quite ready for broad deployment. Version 2 in 1988 expanded the scope, adding some billing capabilities and seeing the first real implementations outside of an academic setting. 2.1 in 1990 incorporated laboratory results through that ASTM merger. This was a major enhancement because lab results are such a high volume message type. Then through the 90s, versions 2.2, 3, 4, and 5 achieved broader adoption. Each version added new message types and refined existing ones. It became the dominant standard for healthcare messaging in America and eventually the world. Then in 2005, HL7 version 3 and CDA took a different approach. And this is where things diverge. The organization decided the V2 approach was too loosely defined, leading to some variability in implementations. So V3 introduced XML formatting and a formal reference information model, a rigorous definition of healthcare data structures. What was the problem? Well, V3 was technically elegant, but complex. Implementing it required significant expertise, and the value proposition of how much better it was than V2 wasn't that obvious, and many organizations were frustrated. Adoption of V3 became limited, primarily to CDA documents rather than for real-time online messaging. So, as a result, FHIR emerged in 2014 as a response to this frustration between the transition from V2 to V3's complexities. It kept the rigor, but made it more practical, using modern web technologies that developers were very familiar with and were easy to employ. So we'll spend a lot of time talking about FHIR. Where is HL7 today? Well, HL7 International is an ANSI accredited standards development organization, which means it follows rigorous processes for developing and maintaining standards. It has affiliate organizations in over 30 countries and making it truly international in scope. Here's a statistic that might surprise you. HL7 version 2 is still used by 95% of U.S. healthcare organizations. Despite being 40 years old, despite newer alternatives, V2 is deeply embedded in the healthcare infrastructure. And when you work in a hospital IT department, you're going to encounter V2 messages constantly. At the same time, FHIR is now mandated for new systems under the ONC Final Rule. If a health IT vendor wants their product certified, it must support FHIR. So we're in a transition period. Legacy V2 systems continue to operate, while new development increasingly switch to FHIR. This dual reality is important for you to understand. You can't just learn FHIR and ignore V2. And you can't just maintain V2 expertise and ignore FHIR. Health and informatics professionals must be comfortable with both. The organization's mission statement is empowering global health interoperability. They've certainly made progress toward that goal, though there's still a ways to go. So let me summarize the evolution in a way you can remember. In 1987, HL7 V1 arrives just as a proof of concept. It worked, but it was quite limited. In the 90s, HL7 V2, the various versions, achieved wider adoption, and its segment-based approach. It is practical, implementable, and solves real problems, but it lacks a formal data model, which leads to variability between implementations. Then in 2005, we had version 3 and the CDA to try to address this variability by introducing XML and a formal reference information model. And the approach was rigorous, but the complexity limits its adoption. CDA documents catch on, but V3 messaging doesn't replace V2 as they had hoped. So in 2014, we come out with FHIR. It arrives as a synthesis, keeping the rigor of V3, but making it practical with web technologies. It's designed to be implementable by mainstream developers, not just healthcare IT specialists. Each version addressed limitations of its predecessors. V2 was practical but informal. V3 was formal but impractical. So FHIR found a middle ground, structured enough to be useful, but simple enough to implement. And now FHIR is government mandated, which changes the dynamics entirely. It's no longer optional for US healthcare information technology. All right, let's take a moment and look at HL7 V2 concepts in a little bit more detail. Even though FHIR is the future, V2 is the present and the past. So you'll encounter it constantly in the field, so you need to understand exactly how it works. Let's look at the conceptual overview of HL7 V2. It's fundamentally message-based. Systems don't share a database or maintain synchronized statuses. Instead, they exchange discrete messages. Like when something happens, a patient is admitted, or a lab result comes back in, or an order is placed, a message is sent. So it's event-driven. A real-world event triggers message creation. Someone clicks Admit Patient in the registration system, and that event generates an ADT A01 message. The message flows to other systems that need to know about the admission, the lab, the pharmacy, nursing documentation systems. Messages are built from reusable segments. A segment is a single line of text representing a specific type of information. So the PID segment contains the patient identification. The PV1 segment contains visit information. You combine segments like building blocks to create complete messages. Fields within segments are separated by a pipe character, the vertical bar. That's why you'll hear V2 described as a pipe-delimited system. It's simple, text-based format is very easy to parse. You can see it. Remember that 95% statistic. This is what 95% of US healthcare organizations are using for system communication. So understanding V2 is not optional, it's essential. All right, let's look at how a V2 message is structured conceptually. A message is composed of segments stacked together, one per line. Every message starts with an MSH segment, the message header, MSH. This segment identifies the sending application and facility, the receiving application and facility, the message type and trigger event, a unique message ID, and the timestamp. is like the envelope of a letter. It tells you who sent it, who it's for, and what's inside. After the header, you have content segments that are based on the message type. PID is the patient identification segment. Demographics like name, date of birth, gender, address, patient identifiers. Almost every clinical message includes a PID segment because almost every clinical message is about a specific patient. PV1 is the patient visit segment. Information about the specific encounter. What type of visit is this? What location is the patient in? Who's the attending physician? And the OBR is the observation request segment, used when you're ordering a test. What test is being ordered, when, and by whom? OBX is the observation result segment, and it's used when the results come back. What was measured? What was the value? What are its units? Is it normal or abnormal? So think of building a message like assembling Lego blocks. You pick the segments you need for your particular message type, stack them together in their appropriate defined order. So let me give you a reference list of the segments that you'll encounter most often. This is worth keeping handy when you're working with V2 interfaces. MSH, the message header. Every single message has one. It contains routing information, the message type and timestamps. The PID, the patient identification, has the demographics, identifiers, date of birth, gender. This is in almost every clinical message. The PV1, the patient visit, has the encounter information like the visit type, the patient location, the provider, the admission date. Then you've got the OBR, the observation request. It's used in the orders and results to identify what test or observation is being requested or reported. Then the OBX, the observation result. This is the actual result values, for example, for lab results or vital signs, anything that's measured. The DG1 is the diagnosis, typically in the ICD-10 coding. This links clinical codes to the patient encounter. Then the RXA, the pharmacy administration. Medication administration records. So what drug was it? When was it given? What dose? What route? So when you're troubleshooting interface issues, and you will troubleshoot lots of interface issues, knowing these segment codes is essential. If someone says the PID segment is missing the patient's date of birth, you'll know exactly where to look. Messages in V2 aren't just sent randomly. They're triggered by real-world events. The trigger event codes tell you what happened. Like A01 is a patient admission. A patient arrived and was admitted to the hospital. This triggers census updates across the entire system. A02 is a patient transfer. The patient moved from one location to another, maybe from the ER to an inpatient unit. A03 is a patient discharge. The patient left the hospital, so it's time to update the census, trigger billing processes, and potentially send records to follow-up providers. Then the O01 is a general order message. Someone placed an order. Could be for a lab test or radiology exam, a medication order. R01 is an observation result, typically from the lab. The lab ran a test and here's the results. S12 is a schedule notification. An appointment was booked or changed. So, the combination of message type and trigger event gives the receiving system full context. When you receive an ADT message with trigger A01, you know exactly what happened. The patient was admitted, and you can process accordingly. So what kinds of real-world events in a hospital workload do you think would trigger HL7 messages? Think about the activities that happen from when the patient arrives all the way through to when they leave. There are a lot of trigger events. All right, let's try to be balanced between the HL7 V2 and its strengths and limitations. The strengths, well, 95% use, so it's ubiquitous. So it's sort of like a de facto standard that everyone uses. It's well understood within the industry. There are decades of collective expertise and training materials, tooling, experience, consulting services. It works with all existing systems. If you have a legacy system from the 90s, it probably speaks V2. The installed base is enormous. Billions of messages flow every day. It's very reliable. These interfaces have been running for decades, and the kinks have been worked out. But there are also limitations. There's no formal data model. The specification allows a lot of optionality. So two, quote, compliant implementations might structure data very differently. So this optionality leads to some variability. So like, what does field OBX5 contain? Depends on who implemented it. It's difficult to extend. Adding new data types or message types means going through a long standards process. It's not web native. V2 was designed for direct TCP connections between systems, not for HTTP, not for REST or modern web architectures. And mobile support is poor. V2 was never designed for smartphones or tablets. So here's the key message. HL7 V2 isn't going away anytime soon. There's too much infrastructure, too much of an investment, too much momentum. But for new development, FHIR addresses these limitations while keeping the strengths. So you need to understand both philosophies. Let's go into a little more depth in FHIR, the standard that's reshaping healthcare interoperability. And this is where the industry is heading. And it's now mandated by the federal government. FHIR, what does it stand for? Fast Healthcare Interoperability Resources. And yes, it's pronounced FHIR. The organization explicitly chose the name for its memorability. The first draft was released in 2014, developed by Graham Greene and others within the HL7 International Organization. The R4 version, released in 2019, became the first normative release, meaning it's stable and won't change. It's upwards compatible. R4 is also what the US government mandated in the ONC Final Rule. So FHIR was developed by HL7 International, the same organization behind V2 and V3, but it's not a competing standard. It's the evolution of HL7's thinking about how to do interoperability better. The design philosophy behind FHIR is to leverage modern web technologies such as HTTP, REST APIs, JSON, OAuth. These are technologies that mainstream web developers already know. They're familiar with them. They're comfortable with them. The goal was to make healthcare data exchange as straightforward as building any other web application. If you can build a web application that calls a REST API and parses JSON, you will have no trouble working with healthcare data. That was the vision. So, what makes FHIR different from its predecessors? Let's walk through some of the key dates and innovations. First, resources. What are resources? They're the fundamental unit in FHIR. A modular, self-contained building block. Patient is a resource. Observation is a resource. Medication request is a resource. Each resource has a defined structure with specific sub-elements and data types. Resources can reference each other, but can also stand independently. Second, there's a RESTful API. FHIR uses standard HTTP methods: get to retrieve data, post to create, put to update, and delete to remove. There's no special transport protocol to learn. If you know HTTP, you know how to talk to a FHIR server. Third, multiple formats. You can use JSON, XML, or RDF, depending on your needs and familiarity. JSON is most common because it's lightweight and JavaScript native, but XML is available for systems that prefer it. And fourth, it's web native. FHIR was designed for HTTP from the start. Security, using OAuth 2.0, is the same standard that secures countless web applications. Identity uses OpenID Connect. These aren't bolted-on additions. They're fundamental to their essential design. Fifth, it's mobile-friendly. Resources are lightweight enough to work efficiently on mobile networks. The JSON format is compact, and this matters enormously as patient-facing apps become more important. Sixth, it's easily extensible. If the base specification doesn't cover your needs, you can create profiles that add constraints or extensions. So this balances standardization with flexibility. And this combination is why FHIR has generated such excitement. It brings healthcare interoperability into the modern web development era. Let's go deeper on resources, since they're the fundamental building block of FHIR. A resource is the smallest unit of data exchange. You can request a single patient resource or a single observation resource. You're not requesting an entire database or arbitrary data structure. You're requesting a well-defined resource. There are over 145 defined resource types in the specification, and the number grows with each release. These cover clinical content like condition and procedure, administrative data like patient and practitioner, financial data like claim and coverage, and workflow resources like task and communication. Each resource has a defined structure. A patient resource always has the same elements: name, birth date, gender, address, and so on. So you know what to expect. This predictability makes parsing and processing straightforward. Resources are organized into categories. Administrative resources include patient, practitioner, organization, location, the entities involved in healthcare. Clinical resources also include condition, procedure, observation, diagnostic report, the clinical content of care. Then the financial resources include claim, coverage, explanation of benefit, the payment side of healthcare. So think of resources as analogous to the database tables, but more self-contained and with well-defined structures. You could think of a patient resource as similar to a row from the patient's table plus associated metadata about the format and version. All right, let's map common FHIR resources to our xHealth database that we've been using in our course. And you can see the correspondence, the parallels. Patient maps to our patients table. It contains the demographics, the identifiers, names, date of birth, gender, addresses, all the contact information. Practitioner maps to providers, contains the provider information, the name, credentials, the NPI, specialty. Encounter maps to our encounters table. It represents a patient-provider interaction, an office visit, a hospitalization, an ER encounter. Condition maps to diagnoses. It represents a clinical condition, a diagnosis, a problem, a health concern. The ICD-10 code goes in the code element. Then observation maps to lab results and vital signs. It represents any measured or observed finding, such as lab values, vital signs, social history observations. Next, the medication request maps to medications. It represents a prescription. What medication, what dose, what frequency, who prescribed it. Then procedure maps to our procedures table. It represents a clinical procedure that was performed with the associated CPT code. Finally, claim maps to insurance claims. It's a claim for payment. So notice how the concepts align, and that's intentional. FHIR was designed to represent the clinical concepts that already exist in healthcare systems. If you've been working with xHealth, the FHIR resource types are familiar. Here's an example, a FHIR patient resource, a very simple example. The resource type field identifies what type of resource this is, and it says patient. Every FHIR resource starts with the resource type. The ID is the unique identifier within the server, like 001 in this example. The name element is structured, very structured. The gender, birth date, and address follow similar patterns. They're structured. We know what to expect. So if you work with JSON in web development, this should look very familiar to you, because that's exactly the point. FHIR uses standard web formats that millions of developers already know. You don't need specialized healthcare training to parse this. Any developer who knows JSON can work with this. Compare this mentally to the pipe-delimited v2 format with segment codes and field positions. Which would you rather work with if you're building a modern web or mobile application? I think it's clear that JSON's easier to work with. Here's one more example, an observation resource representing a lab result for hemoglobin A1C test. The status field indicates this is a final result. The lab is done, and this is the official value. Other statuses could be preliminary or canceled. The code element is where LOINC coding comes in. Notice the structure. There's a coding array, and each coding has a system URL identifying where the code comes from, the code itself, and a human-readable display. The system http://loinc.org tells any receiving system that this is a LOINC code, and the code 4548-4 is specific LOINC code for the hemoglobin A1C. But it's in a human-readable string. And the value quantity gives us the numeric result, that's 7.2 in there, with the units, which is in this case a %. The subject element references the patient's resource this observation belongs to, patient 001. This is how FHIR resources link to each other. So let's look how this maps to our lab results table. The LOINC code column maps to coding code. The result value column maps to value quantity value. The patient ID column maps to subject reference. The structures parallel each other because both are representing the same underlying clinical concept. FHIR uses standard HTTP methods, which mean the API is intuitive if you've done any web development before. GET retrieves resources, like get patient 123 retrieves the patient with ID 123. Get patient name equals Smith searches for patients with the name Smith. The URL patterns follow the REST conventions. Post creates new resources. Post patient with a patient resource in the body creates a new patient. Put updates existing resources. Put patient 123 with an update patient resource replaces the existing patient line. And delete removes resources. Delete patient 123 would delete that patient, though most healthcare systems restrict delete operations for obvious reasons. So the base URL might be something like https FHIR hospital.org R4, and then you add the resource type to any parameters. This is standard HTTP. It works with any programming language that can make HTTP requests. It could be Python, JavaScript, Java, C++, whatever programming language you use. You don't need specialized healthcare libraries, though they do exist to make things easier. Any HTTP client can talk to a FHIR server. And FHIR has evolved through several versions, and the version matters for compatibility. The DSTU1 came out in 2014 as the initial draft, and it was a standard for trial use with 49 resources. It was explicitly labeled as a draft, not ready for production use. Then DSTU2 came out in 2015. expanded testing and added more resources, but it was still in draft mode. STU3 came out in 2017 and was labeled as a standard for trial use, a subtle change reflecting growing maturity, but still not quite final. Then R4 came out in 2019, which was a breakthrough, the first normative release. Normative means the core resources are stable and won't change incompatibly. This is the version the US government mandated in the ONC Final Rule. If you're building a new system for the US market, R4 is what you have to implement. R4B in 2022 was a minor update with some corrections and a few additions. R5 in 2023 is the current development version, adding some new capabilities while maintaining backward compatibility with R4. So for US healthcare work, R4 is the version that matters. When someone says we need FHIR support, they typically mean R4 unless specified otherwise. So let me introduce you to a related specification that extends FHIR. SMART stands for Substitutable Medical Applications Reusable Technologies. SMART. Substitutable Medical Applications Reusable Technologies. So SMART on FHIR defines how third-party applications can securely access FHIR servers. It's built on OAuth 2.0 for authorizations for security, the same standard used by Google and Facebook and all the major platforms for third-party app access. And it uses OpenID Connect for identification. So what does this enable? Imagine a patient who wants to use an app to aggregate their health records from multiple different providers. The app connects to each provider's FHIR server using SMART authorization. The patient grants permission for the app to access their data. The app retrieves the data and displays it in a unified view. Or imagine a clinician who wants to use a specialized decision support tool within their EHR. The tool launches as a SMART app, retrieves the current patient data from the EHR via FHIR, and provides its analysis, and can even write some data back. This app ecosystem model is a significant shift. Instead of all functionality being built into the EHR, EHRs become platforms that third-party apps can extend. So the 21st Century Cures Act explicitly promotes this approach. SMART on FHIR is a big part of why FHIR matters for patient engagement and innovation in healthcare. So let's put V2 and FHIR side by side so that you can see the differences more clearly. The year, that's when we started these things. HL7 goes back to 1987 and FHIR only to 2014. 3 decades of difference. Format, V2 uses the pipe-delimited text. FHIR uses JSON or XML, and JSON being the dominant choice for most modern applications. Then look at the architecture. V2 has message segments. They're arranged in defined structures. And FHIR has resources accessed via REST APIs. The data model. V2's data model is implicit and loosely defined, leading to implementation variability. FHIR has explicit reference model with defined resources and data types. You have to follow their standards. Next, web support. Well, V2 had none. It was designed for direct TCP connections, but FHIR is web native and designed for HTTP. Mobile, very limited mobility apps in HL7 because it was before mobile devices were common. But in FHIR, it's natural. It's designed for mobile. The current status, well, V2 is in maintenance because it's been around a long time, but it's mature. It's been available for a long time, and because of 95% adoption, it's easy to interface with. But the FHIR resources continue to evolve and are under active development. So the US adoption, like we said, 95% for the HL7. The FHIR is now the new law and is mandated for new systems. So when to use which? Let's look at some various scenarios and which standard we're going to employ. In a legacy system, if we're integrating legacy systems, you're probably going to use V2 because they're very familiar with it. You're connecting to a lab system that's been running since 2005, for example. It's going to be speaking V2. You're not going to rebuild that interface. Let's think about a new patient portal or mobile app. Well, definitely you want to go with FHIR because it's got mobile. You need modern development parameters. You need JSON, REST APIs. That's exactly what FHIR provides. And for those of you that may not know what a REST API is, it's a representational state transfer application programming interface, REST API. It's a term you'll hear over and over again, so get used to thinking about it as a representational state transfer application programming interface, API, REST API. And sometimes you'll hear it said RESTful API. Suppose we have a laboratory instrument interface. Well, there's still a lot of hardware interface done there, so that's often still in the V2. Lab instrument vendors have been using V2 for so long, the installed base is so large, it's much easier to employ things that you're familiar with. Some are gradually transitioning to FHIR, but V2 remains highly dominant. Let's think about population health analysis. These are using big data. They're newer, so you're going to expect to use FHIR bulk data. It lets you export large databases for analytics rather than querying record by record. You're not going to do that in V2. How about patient data access under the 21st Century Cures Act? Well, that's the law for FHIR. If you're providing patient access to their health information, FHIR is the required format. And finally, real-time ADT notifications. This is admit, discharge, and transfer. You could use either one, depending on your infrastructure. V2 is available frequently. Doing ADT messaging has been well established, but FHIR is gaining momentum. So, the practical reality is that most organizations use both. You might receive V2 messages from legacy systems, store the data in your database, and expose it through FHIR APIs for patient access. The interoperability engine translates between the different worlds. So what are the FHIR key takeaways? Let's summarize what you need to remember about FHIR. Let's look at all the different issues. FHIR is modern, it's web native, it's got standards for health data exchange, it leverages technologies that mainstream developers already know. Resources are modular building blocks, like the patient, the observation, condition, 145 others. Each is self-contained within a defined structure. The RESTful API uses standard HTTP methods. You've got GET, POST, PUT, DELETE. No special protocols are necessary, no special tooling. The JSON XML formats are familiar to developers. It's useful when we're using FHIR. R4 is the American mandated version. It's the law. And Smart on FHIR enables secure third-party applications, creating an ecosystem around electronic health records. FHIR is designed to complement and eventually replace HL7 V2 for most use cases. The transition, though, is very slow and is going to take quite some time. Now, before we go forward, if you have any difficulty with questions about FHIR, please go over the last few slides again. Be sure you have comfort level this before you proceed. We're getting ready to go on to a new section. So take a minute, take a breath, go back a few slides, and go over this again because it's very technical, but it's very important as we go forward. Now let's look at openEHR, which takes a fundamentally different approach to interoperability problems. Where HL7 focuses on messaging and exchange, openEHR focuses on clinical models and long-term data persistence. What is openEHR? It's an open electronic health record. It was founded in 2000, though its roots go back into the 1990s. It started in Europe and was funded by the European Union. Unlike HL7, which is primarily a messaging standard, openEHR is a complete EHR architecture. It provides specifications on how electronic health records should be structured, how clinical content should be modeled, and how data should be stored over the patient's lifetime. The key innovation is two-level modeling. This separates clinical knowledge from technical implementation in a way that's quite different from HL7's approach. We'll dig into this concept because it offers insights even if you never implement an openEHR system. openEHR is maintained by a nonprofit foundation with a global community of clinical informaticists, software developers, and healthcare organizations. Let me give you the history. In the 1990s, the European Union funded a research project called GEHR, the Good European Health Record Project. And the goal was to define requirements for electronic health records that would work across countries with their different languages, healthcare systems, and clinical practices. In 2000, after the European Union project ended, the openEHR Foundation was established to continue the work as an independent nonprofit. The first specifications were published in 2003. A major milestone came in 2007 with the launch of the Clinical Knowledge Manager, the CKM. This is an international library of clinical models where archetypes are developed, reviewed, archived, and shared. It's like the GitHub for clinical content. Now through the 2010s and 20s, adoption has grown, particularly in Europe, Australia, and some parts of Asia. There's also increasing collaboration with HL7. The organizations aren't competitors, but rather addressing complementary aspects of interoperability. In June of 2025, there was a notable HL7 openEHR collaboration workshop focused on aligning the standards where the two systems overlap. The two-level modeling concept. This is the core concept that distinguishes openEHR. Let me explain it carefully because it's kind of a different way of thinking. Traditional software development mixes clinical knowledge with technical implementation. If you're building an EHR system and need to capture blood pressure, you define a database table with systolic and diastolic columns and build a user interface with input fields. You write validation logic and so on. The clinical knowledge, what blood pressure is, or what data needs to be captured, is embedded in the software. What happens when clinical requirements change? Maybe clinicians decide they need to capture patient position during measurement or cuff size. You have to modify database schemas, update application code, change UIs. It's a developmental project. openEHR separates these concerns into two levels: the information level, the reference model. And they handle the technical structure. It defines generic data types and structures, any numeric value, any date, any coded value, any text. These are stable and rarely change. The knowledge level handles clinical content through archetypes and templates. An archetype defines what data should be captured for a clinical concept like blood pressure. A template combines archetypes for a specific use case. So here's the key insight. Clinical knowledge can evolve independently of software. When clinicians decide they need to capture cuff size, they update the blood pressure archetype. Applications that use the archetype automatically get the new data element. No coding changes are required. The software just knows how to render and store archetype data. And this is a powerful idea even if you never implement an openEHR system. Let's go deeper on archetypes. An archetype is a complete model of a clinical concept developed by the clinical domain experts. The word maximal is key. Archetype doesn't just capture the common data elements, it captures all possible data elements for that concept. And most implementations won't use everything, but everything is predefined. Let's take the blood pressure archetype. It includes systolic and diastolic blood pressure, of course. Those are essential. But it also includes mean arterial pressure, cuff size, patient position during measurement, the device used, the location of the measurement, right arm, left arm, leg, comments, and even more. So why does it include all this? Because some clinical situation somewhere might need it. A study of hypertension might need a patient position. A quality initiative might need cuff size to identify measurement errors. By defining these elements in the archetype, they are available when needed. Who develops the archetypes? Well, clinical domain experts, not just software developers. Archetypes go through a review process in the Clinical Knowledge Manager where clinicians worldwide can comment and suggest improvements before it's finalized. The CKM, the Clinical Knowledge Manager, is international. It's the same blood pressure archetype used in Australia, Norway, Slovenia, and wherever openEHR is implemented. So this creates some semantic interoperability at the clinical concept level. If archetypes are maximal, templates are specific. A template takes one or more archetypes and constrains them for a particular use case. For example, consider a vital signs check template for routine nursing assessments. It uses the blood pressure archetype, but only includes systolic and diastolic, not that mean arterial pressure, not the cuff size, not the device type. It includes constrained versions of body weight, heart rate, and temperature archetypes. So the template says, for this workflow, capture these specific sub-elements from these archetypes. It narrows the maximal definition to what's actually going to be used. Let's look at another example, discharge summary. The discharge summary template combines archetypes for diagnosis, medications, procedures, and follow-up instructions into a document structure appropriate for discharge. Templates are typically developed locally. An organization creates templates that match its particular workflows. But templates built on archetypes that are developed and shared internationally balances the local customization with global standards. So here's an example of the archetype and template combined. Let's make this concrete with a visual example. Let's consider again that blood pressure archetype with all its maximal data elements, including systolic, diastolic, mean arterial, patient position, cuff size, device type. Now we create a vital signs template for routine nursing assessment, and we make choices of which sub-item is to employ. I'm going to have systolic, diastolic, mean arterial. Well, we don't need the mean arterial because we're not going to use it in this workflow. The patient position, we'll include it and make it mandatory. Our quality team decided they wanted that. Cuff size, they decided they didn't need this. Comments, we decided we wouldn't include that. So this template constrains the archetype to just what's needed for this particular application. But the underlying archetype remains available. If different templates needs, such as cuff size for a hypertension research project, it can be added later on. So the vital signs template also pulls in constrained versions of body weight, heart rate, and temperature archetypes. Together, they define what a vital signs check captures in this specific instance, this use case for this organization. So let's think about the openEHR benefits. It's future-proofed. Clinical knowledge can evolve without requiring any software changes. You can add a new element to an archetype, and applications that use the archetype automatically will support it from day one. If you have clinical-driven design, domain experts define the clinical content, not software developers trying to guess what's needed. This Clinical Knowledge Manager, the CKM, review process involves clinicians worldwide, so you have a big support system that can help you develop your archetypes properly and thoroughly, comprehensively. Reusability, archetypes are shared internationally. You don't reinvent the wheel for every implementation. The blood pressure archetype used in Australia is the same one that's used in Norway. What about interoperability? Shared clinical models enable semantic interoperability. If two systems both use the same blood pressure archetype, they understand each other's data at a very deep level. Query friendly. The archetype query language allows standardization of queries against the clinical model. You can query for all blood pressure observations regardless of which template they came in. And finally, vendor neutral. Data stored using openEHR structures isn't locked to a specific EHR vendor's proprietary format. So you don't have the Cerner versus other dominant EHRs, complexities, and competition. You can migrate between systems without losing any semantic richness. openEHR plus FHIR, are they competitive or complementary? Here's an important point I want you to take away. openEHR and FHIR aren't competitors, they're complementary. openEHR focuses on data at rest, long-term storage and persistence. How do you store a patient's health record in a way that preserves meaning over decades? How do you ensure that a blood pressure recorded today can be understood and interpreted 20 years from now? FHIR focuses on data in motion, exchange of data, and APIs. How do you send patient data from one system to another? How do you expose data for third-party apps? How do you enable patient access? These are very different problems that benefit from different approaches. So openEHR's modeling approach, maximal archetypes that get constrained only at runtime, is excellent for long-term persistence, whereas FHIR's approach, define the common case well, extend via profiles, is excellent for practical exchange. There's increasing recognition that the standards should work together. The June 2025 collaboration workshop between HL7 and openEHR produced this statement. This collaboration is about the mutual benefit of bringing together the complementary strengths of HL7 and openEHR. You might see architectures where data is stored using openEHR structures for long-term persistence, but exposed via FHIR APIs for data exchange. The two standards complement each other. Now let's go on to the U.S. regulatory landscape. This is Section 6. We'll look at the regulatory context that's driving the standards adoption in America. Technology alone doesn't achieve interoperability. Policy and regulation play crucial roles. What is the 21st Century Cures Act, which was first promulgated in 2016? This was landmark legislation signed in December 2016. While it addresses many aspects of healthcare beyond interoperability, like drug development and mental health and precision medicine issues, the interoperability provisions are what matter for our purposes today. And the key provisions related to health information technology are that the law prohibits information blocking. Providers and health information technology vendors cannot deliberately prevent data sharing without legitimate reason. This was a direct response to accusations that vendors were making interoperability difficult to try to lock in their customers. It requires patient access to their electronic information. Patients have a right to their data in electronic form. So it mandates the use of standard APIs for patient access. No more requiring proprietary portals. Patients should be able to use apps of their choosing to access their data. It establishes penalties for noncompliance, and this gives the provision serious teeth. The implementation came through the ONC Final Rule in 2020, which we'll look at next. The Cures Act set the direction. The Final Rule made it specific. The ONC Final Rule, issued in March of 2020, puts specific requirements behind the Cures Act mandates. Let's highlight the key points. The API standard. HL7 FHIR R4 is mandated, not a standard API, specifically FHIR, specifically version R4. This is what certified health IT must support. Information blocking. It's prohibited with 8 defined exemptions covering legitimate reasons like privacy protection, security concerns, and technical infeasibility. The exceptions are very narrow, well defined. Then thirdly, patient access. All electronic health information must be accessible to patients electronically without special effort. No making patients jump through hoops. Fourth, no special effort. Data must be exportable in computable format. Computable means machine readable, not just PDFs, but structured data that applications can process. And finally, compliance dates. Compliance dates were phased between 2020 and 2023, with most requirements now active in place. So, this regulation is why FHIR matters so much in the U.S. context. It's not just a good idea, it's required by law for certified health information technology. Let's look a little bit more deeper at information blocking. It's central to the regulatory framework. The definition: any practice that prevents or materially discourages access, exchange, or use of electronic health information is information blocking. Note the word materially discourages. You don't have to completely block access to violate the rule. Making it unnecessarily difficult is also prohibited. Now, who does this apply to? 3 categories: health IT developers, the vendors, health information exchanges, big data troves, and healthcare providers. Each has somewhat different obligations, but they're all subject to the same rules. The penalties can reach $1 million per violation. There are 8 exceptions where blocking might be permitted, like protecting privacy of individuals, protecting security of electronic health information, infeasibility due to technical difficulties, recovering costs reasonably incurred, and responding to legitimate requests from providers, licensing, interoperability elements, and maintaining and improving health IT. But these exceptions have specific criteria. You can't just claim security and refuse to share data. You have to meet some defined conditions. The rule became effective in April of 2021. Enforcement is highly active. What is the USCDI, the U.S. Core Data for Interoperability? It's a different kind of standard from HL7 or openEHR. It defines what data must be exchangeable, not how to exchange it, but what must be available. The definition: a standardized set of data classes and elements for nationwide health information exchange. Think of it as a common vocabulary for what data must be shareable. What is the purpose? When we say systems must be interoperable, USCDI defines specifically what data that includes. Demographics? Yes. Lab results? Yes. Radiology images? Not so sure. That's a little gray. So the list is currently very explicit. USCDI is maintained by the ONC, the Office of the National Coordinator for Health Information Technology, and it's updated once a year. Each version adds new data classes based on industry input. Certified electronic health records must support the USCDI exchange. If a data element is in the USCDI, certified systems must be able to send and retrieve it using the standard formats. So what's happened with the USCDI over years? Version 1, back in 2020, established the foundation with 16 data classes. Version 2 added things like sexual orientation and gender identity, reflecting the importance of capturing equitable care. It also included many aspects of the social determinants of health. In 2022, we expanded health equity elements and added some public health reporting requirements, partly in response to COVID-19. Version 4 in 2023 added substance use history and expanded laboratory result specifications. Version 5 in 2024 added orders and observation classes covering the request side of clinical activities. Version 6 in 2025 added care plan, device ID, and family history. So, each version expands what must be interoperable. You, as a healthcare informatics professional, should track these updates because they affect what systems are required to support. All right, now let's bring everything we discussed back to the HealthX database that we've been working on all semester. Let me show you how xHealth tables map to FHIR resources. This mapping isn't accidental. xHealth was designed with FHIR compatibility in mind. The patient table simply maps to the patient resource. The patient ID column becomes the identifier. The first name and last name columns become the name element. Date of birth becomes birth date. Gender maps directly. The providers table maps to the practitioner resource. The NPI column becomes an identifier with the NPI system, specifically mapping to qualifications, specialty. The encounters table maps to encounter resource. Encounter type maps to class. Status maps directly. Then the diagnosis table. It maps to the condition resource. The ICD-10 code maps to the code in the ICD-10 CM system. The medications table maps to medication request. The NDC code maps to code with the NDC system. And the lab results table maps to observation. The LOINC code maps to codes within the LOINC system. The result value maps to the value quantity in the FHIR system. And finally, the procedure table maps to the procedure resource. The CPT code maps to the code within the CPT system. This alignment is intentional. When you understand both the database structure and the FHIR resource model, you can see how data flows from SQL, Postgres, to the FHIR system and back. Let's look at the coding systems in xHealth. These aren't arbitrary. They were the standard coding systems used nationally and internationally required for interoperability. Remember when we covered coding systems in week 1? Now you're seeing them in database context. You can see how they map to the FHIR system and identify coding systems in resources. This connection from week 1 coding systems to database columns to FHIR resources is exactly the kind of integration that you want. Why this matters for xHealth? Let's make the practical point explicit. xHealth was designed to apply to standards from its outset. It has standard coding columns, ICD-10, LOINC, CPT, NDC. These aren't nice-to-haves. They're essential for interoperability. The table structure is FHIR mappable. The conceptual alignment between tables and resources makes transformation straightforward. The data elements align with USCDI. The columns in xHealth cover the USCDI required data classes. So what does this enable? Future compatibility to export xHealth data as FHIR resources. You could build an application layer that transforms Postgres SQL query results into FHIR JSON code. The database design anticipated this need. So here's the teaching point that I want you to take away today. Good database design anticipates interoperability needs. You don't build a database first and then try to make it interoperable later. You think about the standards from the beginning. When you design healthcare databases in your career, consider what coding systems should I include? How will this data map to FHIR resources? What USCDI data classes am I supporting? These questions should inform your schema design from the beginning. So let's show you the conceptual flow from a SQL query to the FHIR resource. At the bottom of your stack, you have your xHealth Postgres database, tables with rows and columns. You write an SQL query. Select patient ID, first name, last name, date of birth, gender, address city, address state from patients, where patient ID equals 123. And that query returns a result set, rows and columns of data. In the middle, you have an application or an API layer. And this is where transformation happens. The application takes the flat row from the database and restructures it into the nested JSON format that FHIR requires. At the top, you have the FHIR resource in JSON format. The resource type is patient. The ID is 123. The name is structured. And the address are all properly formatted. The SQL skills that you're learning are the foundation. You have to be able to get data out of the database. The standards knowledge tells you what structure the output needs. All right, we've come to a conclusion. Let's bring the session to a close and make sure all the key points are clear. Here are our takeaways, 7 of them. Interoperability enables meaningful health data exchange, not just moving bits, but ensuring the receiving system actually understands them. This matters for patient safety, efficiency, and care quality. HL7 version 2 from 1987 remains ubiquitous with a 95% adoption rate, and it uses segment-based messaging with pipe-delimited text. You'll encounter it frequently in the field, so understand it even as the industry is progressing towards FHIR. HL7 FHIR from 2014 is the modern approach. REST APIs and JSON resources, web native design, it's now mandated by the US government for certified health IT software. Fourth, the openEHR uses a 2-level modeling with archetypes and templates. It separates clinical knowledge from technical implementation, enabling clinical content to evolve independently of the software. Very powerful. Next, the FHIR and openEHR are complementary, not competing. FHIR excels at exchange, openEHR excels at the long-term persistence and storage of data. Many architectures use both. Next, the US regulations, the 21st Century Cures Act, the ONC Final Rule, the USCDI. You must be familiar with all of these if you're a healthcare IT professional. And finally, let's look at our example, our xHealth application. This demonstrates using the standards, doing database design that's easy to do interoperability with, since you've already included the necessary requirements for intercommunication. If you have coding system columns, FHIR mappable structure, USCDI aligned data elements, it shows how you can apply these principles in practice. So let's see what's going to happen this was the 3rd part of the 4th week. We've got one more little section to come up with. We'll do an integration exercise. We'll work through all these scenarios and combine the SQL queries with standards awareness, seeing how all the skills you developed this week work together. So then we'll preview week 5 next week, which covers data manipulation language, DML operations. This is where we insert data, update records, delete records, or for modifying data. We'll We'll learn join operations to join tables together. They come in different flavors, the inner joins, left joins, right joins, full outer joins. These are very complex concepts, but we'll go over them with enough examples that you'll understand, because once you have that foundation, your database programming becomes far simpler, because we need to be able to combine data from multiple tables. We'll examine what the EHR vendors like Epic and Cerner and how interoperable they are, and we'll do a deeper dive into the USCDI.